Hi dentist, how are you? This is Muhammad Musa from AFK Study Plan. Today is Sunday and this is a day for our weekly newsletter. Last week we did 5 questions, mostly coming from orthodontic discipline, and I see people love this concept. So today let's remake it again. But today we are making questions coming from epidemiology and like study of epidemiology, and mix it with other concepts not to be very dull. So as usual, tags will be down here. On the left side of the screen, you can see the previous newsletter. You can try to do the quiz for the questions, and I will post the next 5 questions. And from the upper right side of the screen, you can click the clip and then you can download the PDF file to share it, and feel free to share the file. Give me your feedback. With that being said, let's just start it. First question from surgery. A 60 years old patient reports for the extraction of a diseased maxillary right second molar, which is the only tooth in that quadrant. Care must be taken during extraction to prevent. And I know the wording of the question is little weird. It sounds like someone from London trying to give you a question, and this weird English, you might see it in the exam. So reports meaning like coming to your office, do extraction of a disease like infected or badly broken tooth, which is maxillary right second molar and the only one in the quadrant. So this patient, cut it short, this patient coming to your office to extract upper 7, which is the only tooth in this quad. Care must be taken during extraction to prevent. And then moreover, he giving you option which is really also weird. Other osteitis, displacement of the tooth into pterygomandibular space, displacement of the tooth into masteric space, alveolar bone fracture. So what's the meaning of alveolar osteitis? This is alveolar osteitis. You know this, I think you did see this one before. This is dry socket. It's a hole inside the patient mouth, and it's like, and it happens in place of extracted wisdom tooth, which most commonly would be the lower one. So alveolar osteitis is the dry socket, and this is happening due to delayed healing, but it's not associated with an infection. This post-operative complication causes moderate to severe pain, but is without the usual signs and symptoms of infection, such as fever, swelling, and erythema. The term dry socket describes the appearance of a tooth extraction socket when the pain begins. So this is extremely important. I would like you to pay super attention here, because like a complication after extraction is very common in the exam, and you should differentiate between infection, between swelling, and between this one, dry socket. So for dry socket, we have two strict requirement, so you can diagnose this one as a dry socket. Your patient will tell you, I have pain developed in third or fourth day after removal of the tooth. Almost all dry socket occur after removal of lower molars, so we can say it happened in lower molar most commonly. It might happen in upper teeth, but most commonly happen in lower 3-8 and 4-8. So this is the first requirement, being developed in third or fourth day, not in first day. And secondly, the patient will tell you, I have foul odor inside my mouth, and when you open the patient mouth, you can see this hole. When you look at inside, you can see bare bone, you can see pus coming from inside the socket. So to diagnose something to be dry socket, it can be second day, third day. It cannot be with bleeding. It cannot be with swelling. And see, you can see here, usual signs and symptoms of infection such as fever, swelling, and erythema usually is not there. Okay. On examination, the tooth socket appears to be empty with a partially or completely lost blood clot. Is sensitive and is a source of pain, the exposed bone here. The dull aching pain is moderate to severe, usually throbbing in nature and frequently radiating to the patient ear. And lastly, the area of the socket has a bad odor, and the patient frequently complains of foul odor or foul taste. So to diagnose a dry socket after osteitis, it should be happening third or fourth day after. Patient will have no signs of a fever, swelling, erythema. Patient will tell you, I feel throbbing pain, severe pain, and foul odor or foul taste or bad odor. And when you open patient mouth, you can see this socket here. Okay, so let's explore other option. He speak about pterygomandibular space or masteric space. So upper teeth cannot go to this space because this space is related to the mandible. As you can see in this diagram, masteric is lateral to the mandible and pterygomandibular space is medial to the mandible. So these two options are not correct here because we speak about upper seven. And here come the importance of you reading the question carefully because this might happen, but we speak here about maxillary second molar. So it cannot be displaced directly to this space. I don't know how it can be displaced here. Okay, so the last option, fracture of the alveolar bone. And here is the PA, like showing this one. So we speak about second molar isolated here. You can see maxillary sinus pneumatization. You can see alveolar bone loss. This tooth like has a thin chill of bone around it, and there is maxillary sinus pneumatization. Space is so small and bone here is so less and so weak around this tooth. So most commonly when you're trying to extract this tooth, most commonly the bone here will be fractured, maybe maxillary tuberosity will be fractured here. So the care must be taken during extraction to prevent, yes, correct, alveolar bone fracture. So here the question, I know the wording is weird, but like I tend to give you wording which is like, wow, it's not common here, but like with like slight attention, you can get to know what he means, and you should write it down. Maxillary right second molar, so we know we now speak about upper second molar, not speak about lower, because if you know this, you will never pick these two options. So I would like you to understand alveolar osteitis and how to deal with it. Okay? Let's now start with epidemiology question. Specificity is the proportion of truly diseased person who are identified as being diseased. So here he's giving you two statements and asking you to judge. So this is a definition of specificity in the question. And then he's saying false positive results identifies individuals as having a disease, but in reality they do not have. So both statements are true or both statements are false. First statement is true, second is false, or the first is false, second is true. So before we judge, we need to know this term, specificity, and for sure sensitivity, false positive, and for sure false negative. So when you understand it, it will be easy for you to answer the question. And here I'm going to discuss it in depth. And if you want to know more about epidemiology studies, like beneficence, maleficence, non-maleficence, autonomy, we did a whole lecture about it. You can check the link here. It was a live session and we recorded, and then you can check it. You can watch the video and even download the PDF. Okay, so let's start with sensitivity and specificity. Sensitivity is proportion of patient with a disease who test positive. So sensitivity, to cut it short for you, is for disease. Specificity or for like not disease or the healthy status. So when we say this test has high sensitivity, meaning this test, when we do it for like random number of patients, it give a result maybe like 90% to be diseased. And we have our gold standard test to say yes, 90% are diseased. So this test has high sensitivity. So let's explain more. I will give you more visual so you can understand it. While specificity is proportion of patient without a disease who test negative. So in the same test, 10 out of 100, it was negative and it was truly negative. So this is the specificity of a test. So when we introduce a new test, we want to do randomized clinical trial to know this test can be reliable, can be relied on or not. So how we can say it's reliable or not? We use these four terms: sensitivity, specificity, true positive, and false positive. So we can decide this test is good or not good. So let's go more. So the test correctly identify every person who has the target disorder to be diseased. So this means sensitivity is 100%. So this test is extremely correct. This test like identified every patient. So this test is like most likely to be as accurate as the gold standard test. So this test can be identified as a good test. And in the same condition, the test correctly identifies every person who does not have the target disorder. So specificity of the disease of this test is also 100%. This is like, for example, I cannot say like this test is 100% sensitivity and 100% specificity. So it depends on like reliability we aiming. This test is like very rapid and easy to be done. So we do not anticipate this test to be very sensitive, but there is limit where we say, okay, this can be used. This can be like it's easy to be done. Like remember when COVID test, like this easy to be done, but at the same time is sensitive enough to rely upon the result it's coming from this test. So statistical outcome to be true positive. So sensitivity giving you the true positive, and ideal test result to be negative test result, and the other way true negative or positive test result. At the end of the day, there are definitely not positive. They do not have it. So if we have this test and we rely upon this test, so if our patient, we did this test and it was negative, so we making sure 100% this patient does not have this disease. And the other way, if the test it was negative, so we are 100% sure this patient does not have this disease. So if you are a little lost, so let me give you another visual so you can visualize it more. So look here. So we have this circle. You see the green part and the red part. This green and red part combined has how many dots? Correct. It has 8 dots. The 8 dots inside, there is 5 on the true positive side and 3 in the false positive side. So this circle represents the test. We did the test for a sample of person about a COVID test. And then this test said like 8 patients out of this group of people we did the test for has a disease. But in reality, only 5 has this disease and 3 was false positive. So this test identified 8 to be diseased, but in reality, only 5 to be diseased and 3 were false positive. So here the relevance about how we are going to depend on this disease. So 5 out of 8 of this test was positive while they are true positive. So here we can rely upon this test and say, okay, so this test, we can make it equation to give a sensitivity. So sensitivity will be the true positive divided by true positive and false negative. So we should all the positive to be divided by the true positive only. So we get a number to say this test sensitivity is this much. So in this example, we have 5 to be true positive, and all positive or all false negative are all false negative in this side to be. So we are going to say 5 divided by 12. So we're getting the number. So this number represents sensitivity of this test. So here we can wrap it up in this one. So we have the predicted, which is the new test we are going to do, and actual test. In the actual test, we know this one to be positive. So if it's positive, so we say this result to be true positive. And if our test saying is positive, but in reality it's not positive, so we say it's false positive, and the other way for the other side, false negative and true negative. So this is the meaning of these two terms. So here when the question saying specificity is the proportion of truly diseased person who identified as being diseased. No, this is the sensitivity, so this statement is not correct. And the other statement, false positive results identify individual as having a disease, but in reality, they do not have the disease, and which is true. So in this question, the first statement is false because this is a definition of sensitivity, and the second statement to be true. I would like here you to stop the video and go back to watch the game and try to understand the two concepts, sensitivity, specificity, and true positive and false positive, and to combine it in your brain, find an acronym so you can remember it. It will be easier for you when you understand the concept. Any question coming in this topic while you are trying to apply the knowledge you have, it will be so easy for you to answer the questions. Okay. Third question from epidemiology. After completing endodontic treatment on a heavily restored molar, so here you did root canal treatments on a tooth which is badly broken, you recommend to the patient to fabricate a crown on the tooth. So you recommended to the patient fabrication of a crown on the tooth. Which ethical principle does recommending a crown satisfy? So you did something for your patient, which is RCT, on a tooth which is badly broken, and then you told your patient, hey, you know this tooth is badly broken, you should do a crown for this tooth. So which ethical principles you did follow? Beneficence, non-maleficence, veracity, autonomy. So here I'm going to speak only about the correct answer. If you want to know more about it, so please watch this video to give you the whole concept about these 4 terms and how to identify these terms and how you can apply it. So today we are going to speak only about beneficence. Beneficence is do good, act to the patient, benefit of the patient. So you're going to benefit, so beneficence for your patient, to give dental care timely and competently. Meaning, you are going to do root canal treatment for your patient, so you are not going to do it in 3 visits because this is not beneficence for your patient and not beneficence for you. Consider patient's need and value. So if patient come to your office saying I like he has stains in his upper anterior teeth, and I say this more than once, patient has stains in upper anterior teeth, and you say, okay, so this stains your teeth appears not natural. So how about doing filling for this teeth? No, he said no. He loved the tooth, the way it looks. Maybe this is a tradition in his tribe. I did see this patient a lot, or maybe they did some tattoo inside his teeth. Like this is a science of beauty in this culture, so you should respect this culture. No matter the contract, insurance dentist to treat all patients equally. So you do not pick, okay, I will treat this patient only. You don't have insurance, okay, I will treat you because you're paying out of your pocket. And this patient has bad insurance or like community insurance, or this patient has governmental insurance which pay not too much fee guides. So I'm not going to treat them or book him after 2 weeks. This is like against beneficence. Community service, you go to do community service, you go to contribute to your community, give some lecture about the importance of cleaning the teeth for the kids in the school near to your house. During public health crisis or emergency, dentist ethical obligation to the public may subside the dentist ethics obligation to individual patients. So you remember during the COVID situation, so when patient come to the office, we used to do the treatment that is necessary to be done for the patient. I'm not going to do veneers for a patient and like expose everyone in the office for a result and the patient and giving him more one appointment, and while other patients where we were working like in limited capacity need root canal treatment, stuff like this, because I'm going to do this because it's beneficent for me, giving you more money. So this is not correct. So you should consider everything in the equation, not only yourself and the patient only. Okay, dentists should share their researches and development, report suspected abuse, neglect, must keep knowledge of how to identify abuse, neglect, and when to report abuse is mandatory, because this is a big story. I would like recommend you to go to watch the whole video so you understand the concept about it. But this also about the beneficence. And here we speak about the age. So patient between 0 and 12 years old has no mental or physical capacity. And then you should get the consent for everything you are going to do for this patient for his from his parents or legal guardian. And there is a gray zone area of ages from 12 to 16. So he has no physical capacity, but mental capacity is questionable. Meaning, if this patient coming to your office to do cleaning and his dad did approve the cleaning from the previous visit, like you give him recall after 3 months, and he's booked to do cleaning and x-rays, so you don't need to get the consent from the dad, because you can see the dad did give you the consent before, and this patient has like capacity, physical capacity to say okay. But in the same context, if this patient is going to do extraction for a teeth, which is wisdom teeth, no, at this point, same patient, you need to call the parents and confirm that, and preferably to let the parents come to the office and sign the consent. From ages 16 to 18 has mental capacity, but physical capacity is questionable. And this is different from one province to other. So the area between 12 and 18 is little shady, but the general guideline, if you are going to do treatment which is like not invasive, you cannot get this patient to do Invisalign, sign a contract for Invisalign, or do like hypothetically implant for him, or do extraction for a wisdom tooth. No. But if you are going to do simple filling, or if you are going to do cleaning for this patient, a recall, you can do it. Patient more than 18 had both mental capacity and physical capacity. Elderly patient, if he or she has no physical capacity, you must report the abuse. And this is one of the area where you should report the abuse. So if your patient has no physical or mental capacity, meaning this child, like 12 years old up to 12, so you should report it. Or you feel this patient is elderly enough, has dementia and cannot control it, so you should report it regardless. But if it's adult patient, you should not report it. You should give him the option, telling him, okay, this is the resources where you can call someone to help, but you never report it. You just tell the patient about, I feel some abuse, you are being abused. So this is the resources where you can call to ask for help, and you never report this one. Okay? Beneficence is to promote welfare of patients, respect patients' right to self-determination and confidentiality, Adult patient can decline that the dentist report abuse or neglect, as we mentioned, not to be reported where the law does not mandate it. So if you see adult has been under abuse and this patient has a mental capacity, you just like give him resources and you do not report it. Immunity for good faith reports. Provide a safe workplace that has respect for yourself, for the assistant, for the hygienist, and for everyone. Dentist is to lead the team in a good, helpful environment. So this is not only beneficent for you and your patient, it's also for everyone in the office to have a healthy work environment, for everyone to work in a safe place. So recommending a crown for a patient after doing root canal treatment in a heavily restored molar. So you are following here beneficence. And this concept, you can see question coming from this concept, like it's little tricky. You should like read it again, understand the difference between four concepts and how you are going to navigate. And please, when you read the question, see which he's asking for, the one you satisfy or the one you did break or the one you did sacrifice. So it's one word in the same question will give you a different answer. Okay. Next question from anatomy. Which of the following statements are true with regards to the cranial nerves? Cranial nerve topic are like, it's annoying. I would like to say it's simple, but no, it's not simple. It's annoying because like we didn't study this topic much. And when you see the question about it, it will be annoying, honestly, but you should know about it. So the motor supply to the tongue is through the glossopharyngeal and vagus nerve. Let's see that. The tracheal nerve supplies a superior oblique muscle. The muscle of mastication are supplied by the maxillary nerve branch of trigeminal. Taste sensation to the posterior third of the tongue is through the hypoglossal nerve. This question is like loaded because like you see four statements coming from different topics and you should read it carefully so you can navigate and know which answer is the correct answer. So here we see the tongue. So let's speak about the tongue first and then we navigate our option. So the tongue innervation is a little complicated. So we are going to divide our tongue to be anterior 2/3 and posterior 1/3. And then we are going to divide each area to have two sensation, two innervation. One is spatial sensation, which is like a taste sensation, and the one is the general sensation. So general sensation for the anterior 2/3 of the tongue is coming from the mandibular nerve via lingual nerve. So lingual nerve is going to give you general sensation. But the sensory one is coming from the facial nerve, nerve number 7, via chorda tympani branch. So anterior 2/3 taste sensation from facial nerve number 7 and general sensation from mandibular lingual nerve, so V3. And the posterior 1/3, it has one source for sensory and taste sensation, which is the glossopharyngeal nerve. So this has nothing to do with the question, but I'm here trying to give you the whole information because I don't like when people like aiming for the answer. I would like you to know the concept. And then the motor innervation for the tongue is coming from hypoglossal nerve. So hypoglossal nerve will give you the motor innervation for intrinsic muscle, genoglossal, hypoglossal, siloglossal, but palatoglossal coming from vagus nerve. So to wrap it here for you, motor is coming from hypoglossal except palatoglossal. Posterior 1/3 all coming from glossopharyngeal, anterior 2/3 general from mandibular, lingual, and spatial sensation or taste coming from facial through chorda tympani. I would like you to read it again, get the information, because when you have the information solid, it will be easy for you to get the answer. And then let's speak about muscle of mastication because this is extremely important. So here the question is speaking about innervation. So innervation for muscle of mastication is coming from masseteric nerve, anterior division of cranial nerve number 3. So here the muscle of mastication innervation is not coming from this one, is coming from masseteric nerve, which is the question is speaking about different nerve. Muscle of mastication are extremely important. You should know this information very well. You should know the different names of muscles and like where it's coming, origin, insertion, and the action of each muscle, because when you know this one, it will be easy for you to understand a lot in this question coming for the muscle of mastication. So here innervation, mandibular nerve for lateral pterygoid and medial pterygoid is coming from mandibular nerve, anterior division from cranial nerve 3 via lateral pterygoid nerve, and this one via medial pterygoid nerve. So lateral pterygoid nerve coming to lateral pterygoid muscle through mandibular nerve, and same for medial pterygoid mandibular nerve. So the first two is coming from masteric, and second two coming from mandibular, and anyway, they are all coming from trigeminal nerve through the mandibular nerve. Okay, so this is the muscle of mastication, and here's, I love this picture because like this picture wrap it all. So you see the muscle in the like medial to the ramus. This is the medial tragoid muscle, and it fan up beneath the lower border of the mandible with the major muscle of mastication with the masseter muscle for other side. And up you can see lateral tragoid muscle and medial tragoid muscle, and up in the sky here you can see temporalis muscle. So this view can give you the all muscle of mastication, all five muscle of mastication, and you can correlate them to each other. So masseter and medial tragoid is coming back to back as a mirror image. One is medial to the ramus, one is lateral to the ramus, and lateral tragoid muscle is coming horizontal, and this is the only muscle of mastication which is acting horizontal, and temporalis muscle fan in the upper right side of the skull. So this is extremely important for you to understand this. And last option, speaking about tracheal nerve, tracheal nerve, which is muscle this tracheal nerve is supplying, which is superior oblique muscle. Sadly, I'm sorry to deliver this bad news, but you should remember everything here. You should remember which nerve is going to supply which structure, because this is important. Also, you should know from which part of the brain this nerve originates and through which part this nerve go out. If you have limited time and you feel this is not very easy topic to be studied, I cannot blame you. So at least the minimum you should do, the minimum you should do, facial nerve, trigeminal nerve, you should know it by heart. You should know everything about these two nerves. Facial nerve and trigeminal nerve are extremely important because also, and this is really important for everyone going to do the exam. If you're going to study surgery, like space infection, fracture, this is extremely important topic. So you cannot go to the exam without doing this, without knowing these topics in depth. If you have good knowledge in anatomy part, if you have good knowledge in muscle of mastication, if you have good knowledge in innervation and stuff like this, studying space infection will be extremely easy for you. But if your knowledge here is vague, not very solid, or even you didn't study this part because like, oh, I cannot see question. And if a question come from this part, I will not answer this one. I will just pick C and move. And sadly, I see some dentists think this way, trying to cut corners. No. If you're cutting corners anatomy, it will be very hard for you to study surgery. So I would recommend you to study anatomy well, especially the parts you cannot miss. So I know cranial nerve are extremely annoying. At least you should, this visual, try to memorize it. And facial and trigeminal, you should study it in depth. You should know everything for these two nerves at least. And the other nerves, you should just know from where it originates, where it goes, where it exits the skull, and which structure is going to innervate. But these two nerves, you should know it in depth. Please, you should study these two nerves in depth. Okay, so let's read the question again and read the option. The motor supply to tongue is through glossopharyngeal and vagus. No, we're saying this that. Tracheal nerve supply the superior oblique muscle. Yes, this is the only muscle supplied by tracheal nerve. The muscle of mastication are supplied by maxillary nerve branch of trigeminal. No, it's coming from mandibular or masteric. Taste sensation of posterior third of the tongue is through hypoglossal nerve. No, it's through glossopharyngeal nerve. Okay, so now you understand why we did explain everything. And this is, I love this type of question because it gives you chance to study more than one topic and give you chance to get the bigger picture here. Okay, last question from X-ray. Which of the following is true? An inverted Y landmark and radiograph is formed by the nasal septum and floor of maxillary sinus. So here we're going to pick the true one. The internal oblique ridge is seen as radiolucent line in the posterior mandible, and then internal oblique ridge, which is muscle, which is bony structure, is radiolucent. Like no, radiolucent is plaque. Like in Arabic we say radiolucent aswad, like is plaque, and radio opaque abyad, which is opaque abyad. So radio opaque to be abyad and radiolucent to be plaque, which is plaque. So I know people don't speak Arabic will not relate to this one, but like it's really easy, very easy for everyone to speak Arabic here. I know you will never forget this one because I remember one of my friends told me this one like maybe 15 years ago, like lucent, aswad, like black, and opaque, abyad, mean like white. Overlap between teeth and radiograph is a result of improper vertical angulation, improper horizontal, because like teeth are like oriented horizontal inside the patient mouth, not vertical. So if you do your vertical angulation not very good, so it will have shortening or elongation. But when you have horizontal angulation that is very good, you will have this overlap. So these two options are not correct. Last option, cement to enamel junction may mimic the appearance of root caries. So let's explore the last option. So here, when you look at the X-ray like diagram, like think this one about the X-ray passing through the teeth. So when X-ray is passing through the teeth, it either go through the tooth or in between the teeth. So when it go through, radio opaque central tooth shadow is where the X-ray most commonly absorb it and it will not hit the sensor. So this part of the sensor will be white, as you can see in the dental X-ray, to be white. Why? Because the tooth did absorb it. If the tooth did not absorb it, meaning this X-ray is passing through between the two different teeth, so it will hit the sensor X-ray, so will be loosened, will be black shadow, including the burned out edge of the tooth. What's happening in this phenomena? The X-ray will go through it, but in a part where there is huge contrast difference between the tooth itself and the X-ray passing between the teeth to hit the sensor of X-ray to give you this black, it will give you this criteria at the end. You see this arrow is forming here, so you see it's loosened, and when you see it first you think, yo, this is caries for sure, but this is not caries. This is like we call it cervical burnout, and this is related to cement to enamel junction. Why this happening? Because as we mentioned, the X-ray is going through the teeth, it's totally absorbed in the tooth area, and when it's not absorbed, it will go through to hit the sensor and give you this loosened appearance. And due to the difference in contrast between these two, you see this one. But you might think now, okay, how I can differentiate between this one and a root caries? And the answer is so easy. If you see the loosened part reaching up to the bone, this is not caries for sure. If you see the loosened part, the radiolucent part is reaching up, as you can see in this like left arrow, this you see in the lower left arrow, the lucent is immediately above the bone level, for sure there is not root caries. Why? Because root caries, when it does its job, it will either root, and this one will happen after there is resorption in the bone and gum recession. When the gum recession happen, so the radiolucent area will be away from the bone. So once you see this one, you think this is root caries, and typically this is the appearance of root caries, but you just trace the lucent area. If it's reaching up to the bone level, no, this is not caries. There's cervical burnout, and this is happening due to the difference in radiopacity or like a relative absorption of X-ray between the tooth itself, cement enamel junction, and the area between the teeth. Okay, so this is the option here. So let's go to the first option. So inverted Y, as you see the yellow arrow here, is formed by the floor of the nose and floor of maxillary sinus. So the option was not very accurate. It says speak about the floor of maxillary sinus, which is correct in distal part, but in the anterior part, it's the floor of the nose, not the floor of not the nasal septum. So here, let's go to the option again. First one saying inverted Y is formed by the nasal septum and floor of maxillary sinus. No, it's the floor of the nose and the floor of maxillary sinus. And last option is correct. Cement to enamel junction may mimic the appearance of root caries due to the phenomena called the cervical burnout. So I hope that would be beneficial for you, especially the part speaking about epidemiology. I know this topic is not very popular between dentists going to the exam, and I will tell you why. Because this topic, we didn't study it well during our study back home, which makes sense, honestly. This topic is not extremely important for us, and it might appear in your exam, and it might not. So I see some cycles, there is 5 questions out of epidemiology, second cycle, none. And then people going up and down. Let's study it, let's not study it. Let's study it, let's not study it. And now they even going deeper to ask questions about infection control, PI, chemical indicator, which also covered in the lecture, I speak about it. And then you feel confused. Should I study this part or not study this part? So my humble recommendation to study it at least once. You understand it. Again, this topic, orthodontic topic, epidemiology topic, you understand the topic. When you understand it, and navigate through the question. Try to be calm, read the question carefully. It will be easy for you to answer it. Hope that will be beneficial for you. See you next Sunday.